Preoperative fasting. Rules for pre-op fasting are easy, aren't they? Patients should be fasted for a minimum of 2 hours for clear fluids and a minimum of 6 hours for solids and other fluids. While these absolute numbers have the benefit of simplicity, applying them by protocol often means that patients fast from both fluids and food for long periods of time. And our own audit showed that patients having elective surgery were unable to drink for as long as 16 hours before they had the surgery. So I'm going to take a little deeper look at fasting and see if we can come up with some guidelines for patients that make sense and minimise their discomfort. Why fast patients at all? Well, inhalation of low pH gastric fluid leads to acute lung injury and potentially hypoxemia and respiratory failure. The higher the volume of fluid and the lower the pH that is inhaled, the more likely that serious injury to the lung will result. Inhalation of solids can lead to complete airway obstruction. In a famous case series by a Dr. Mendelsohn looking at regurgitation and aspiration in pregnant women, the only deaths among the patients in the series were those who had regurgitated and aspirated solid material. We employ various strategies to minimise gastric volume and pH for patients having a general anaesthetic. These strategies should be interpreted in the context of other factors that may prolong gastric emptying time and the urgency of the need for surgery. First thing is to ask some questions, and possibly the most important is, how quickly does this person need surgery? For people requiring urgent surgery, general anaesthesia with tracheal intubation provides good protection from aspiration. Pressure to the cricoid cartilage can be applied with loss of consciousness if desired, as this may reduce the risk of regurgitation by occluding the esophagus. If surgery is not urgent, however, waiting to allow more time for gastric emptying may reduce the risk of aspiration and allow use of a less invasive laryngeal mask airway rather than a tracheal tube. The second question you should ask is, when and what did the patient last drink? Water is cleared from the stomach very rapidly indeed in healthy volunteers. It takes less than 20 minutes for half of a 300 ml drink of water to leave the stomach in a group of healthy volunteers, and this is called the gastric emptying half time for water. More than 90% is eliminated within 1 hour. This half time is similar, 23 minutes, for tea with a small amount of milk. Milk given on its own may curdle in the stomach, producing solid matter, so should be treated as a solid for fasting purposes. You can see from the displayed graph that more calorific liquids take longer to be emptied from the stomach. However, for a fruit juice, almost none remains after 2 hours. When and what did the patient last eat? After a large meal, up to 30% of the total volume ingested may remain at 6 hours, and fatty meals remain in the stomach for longer. So the 6 hour rule is no guarantee of an empty stomach in many cases. Are there any factors present that might cause delayed gastric emptying, such as pain, drugs like opioids and alcohol, late stage pregnancy, and abdominal pathology, in particular abdominal obstruction? The presence of any of the above makes assumptions about gastric emptying time unreliable, and airway protection with tracheal intubation is advisable. Are there any factors present which might impair the competence of the lower esophageal sphincter? Many women develop heartburn during pregnancy, and this is due to a combination of increased intragastric pressure from the gravid uterus and reduced lower esophageal sphincter tone from the effects of progesterone on smooth muscle. The confidence of the lower esophageal sphincter may be affected by old age and also hiatus hernia. Ultimately, our goal with pre-op fasting is to minimise the risk of regurgitation and aspiration, but also to minimise thirst and hunger and the associated discomfort for the patient. And we can achieve this using a patient-centred approach based on individuals rather than a wholly protocolised approach. This really means staggering fluid fasting times, in particular for patients who are on elective or emergency lists, rather than applying a one-size-fits-all approach to everyone, i.e. you're on the list so you're fasting from 7 a.m. It just involves a bit of thought and forward planning and good communication with the nursing staff on the ward where the patient is waiting to come to theatre. Patients also need good communication. They can be very nervous about breaching fasting protocols and need a bit of reassurance if you're saying you can have something to drink now or up till 11 a.m. or however, whenever it may be. To try and make things more straightforward for all concerned, there's an increasing trend towards using a sip till send policy for patients having surgery. This means that they can drink clear fluids until the point at which they are sent for by theatre. Given how rapidly fluids are emptied from stomach and the knowledge that there are significant steps after the patient is sent for, checklists and so on, except that a lot of time will pass between sending and the patient coming, and it's very effective in minimising fluid fasting times. We use it universally at the RAH for patients having trauma surgery, and it has been rolled out across several other wards also. Doctors who are new to anaesthesia can be very nervous about patients fasting and tend to be overcautious. Understandably so, they don't want to get the blame for a patient not having their surgery or having their surgery delayed. But I hope this presentation will persuade you that with a little communication with your supervisor, the patient and the staff in the ward, we don't have to subject any patients any longer to prolonged fasts of 12, 16, sometimes 20 hours without any fluid intake, let alone any food intake, before they have potentially major surgery.